All right, common concepts about staging and grading. So staging essentially is, where is your cancer? What is the extent of it? Where has it gone, if anywhere else? Is it local? Or is there distance spread, or is it somewhere in between? Most solid cancers use something called the TNM system. So it's tumor size, nodal involvement, so lymph nodes, and metastasis. Has it spread outside of the site of origin? Brain cancer isn't like this, and we'll get into why in a little bit, because it's a pretty unique cancer itself. The stage is some combination of T, N, and M together, anywhere from stage 1 through 4, and they have lots of different variations in between. Every stage in every different cancer is different. So a stage 2A lung cancer is not the same thing as a stage 2A breast cancer or prostate cancer, etc. So you basically can't really equate all of them, but somewhere in that range you will find basically what extent do you have. Stage 4 almost always means it has metastasized. So it has spread outside of, say, the breast tissue that it originated in, or prostate. And staging as well can be either clinical or pathologic. So usually people will start with a clinical diagnosis. So you have some kind of symptom, you go in to get checked out, they find something. They usually do some kind of scan, whether it's CT scan, MRI, X-ray, whatever. They will find where it is, and then they can figure out what's going on. Pathologic means you have some kind of either biopsy or surgery done. Usually if it's a bigger surgery, they can look at something better under a microscope and give an idea of how aggressive it will be, which will be the next set. But there are different, when people say staging, essentially they're looking for, where is your cancer, how far has it gone, and they have different levels of describing it. Again, brain cancer is unique. We'll go over that in a little more detail when we get to the brain cancer part. But that's when you hear about people talking about staging for any type of cancer, they're looking for, where is your cancer, how far has it gone, if it has. Grading is basically, you look at the cells under a microscope, in this case cancer cells, and you're looking for how closely do they look like a normal cell. It's a process, the technical term for it is differentiation. So cells have different levels of differentiation. You hear about stem cells possibly in research all the time. Those are basically where most cells come from, with their different levels of stem cells. Those are relative, they basically give birth to other cells, and then they become more specialized as time goes on. As you get more and more specialized, you have more specialized function, like a red blood cell that carries around hemoglobin in your body. That's the ultimate level of differentiation that would start as a stem cell somewhere else. So what you're looking for under a microscope for the pathologist that usually looks at this is, how closely does it look like the normal cell that I'm expecting? And it can help predict clinical behavior depending on how closely it looks like that, although it's not exact. So one example, and it gets even more confusing when you look at different types of cancer, because most cancers will have their own different grading system, or some will anyway. They have a very specific grading system, but this is one general one where if they don't have their own specific one, they'll usually mention something like this in a pathology report. So when they look at it under a microscope. Grade X they don't often see, because they will do all that they can to give you some kind of grade, but that basically means they can't tell what grade it is under a microscope, although that's pretty rare these days. And then it ranges from grade 1 through 4. So grade 1 is basically, it looks very close to a normal cell, but you can tell that it is cancerous essentially. And then grade 2, 3, and 4, you get to different levels of differentiation, or how well it looks like a normal cell. Usually the higher the grade, the more aggressive it is, and the harder it can be to control, because that means usually it's getting more aggressive, it's able to divide faster, that kind of thing. But it also will also depend on where this is caught, because if you catch it early, even if it's higher grade, you might be able to be more successful than flip it around and have a lower grade that's caught later. Again, that's a very general statement. Don't hang me on that one. Okay, that's as much time as I wanted to spend on that, but I thought we needed to start from a basis of somewhere before we go into more specifics about brain cancer itself. Pretty rare cancer. about just over 1% of all cancers in Canada and in Alberta as well. So it's a pretty rare condition. And that's of the brain and the central nervous system, which is, so that includes the spinal cord and other areas of the central nervous system. Most will occur in the brain. By contrast, metastases to the brain, so spreading from a different primary tumor, something like breast cancer, lung cancer are very common to go to the brain. They far outnumber what we call primary brain tumors, so that originate in the brain by at least 10 to 1, depending on the statistic that you look at. So if you get a scan and you have something going on in your brain, they will almost always look for a different site of origin because of the fact that it's way more likely for you to have spread from some other cancer that may not have been found yet versus a primary brain tumor. In terms of diagnosis, many of you may experience this or have family members that have, but commonly what will happen is you have some kind of symptom that you will present to medical care, whether it be emergency or not, and some kind of workup is done, usually involving scanning. Most common being initially a CT scan of the head or even of the spine, followed up usually with an MRI. They work together, they're complementary. One is usually a bit better than the other in terms of definition for certain things. CT scans are much faster. They're more plentiful as well. They're less claustrophobic because you're not stuck in a tube, you're in a little donut hole essentially. And they can look for things much more quickly, like if you have signs of because brain tumors can also cause signs similar to a stroke or an acute bleed. You can find that fairly quickly with a CT scan. If you need more detail, MRIs are better, however, especially at finding more subtle lesions or possible cancers in the brain and in the spinal cord. So usually the steps that people will take, that I will see anyways, you'll have a CT up front and then an MRI to confirm any findings that were found or if there's any question about what's going on. But one isn't necessarily a lot better than the other. The main point will be whatever follow-up, usually you want to stick with whatever you've chosen. So if you do an MRI consistently, you try and do MRIs more often so that you can compare them more easily. You know, in a quick pinch, the CT scan versus an MRI really doesn't matter which one you get. They're usually looking for something that may be changing rapidly. Okay. So my colleague that comes after me, Dr. Van Landegem, sorry Frank, he will go over, I think, of this in a little more detail from looking at his description. I don't actually know what his presentation is. This is going to change in the future as well as they change essentially how brain cancers are graded or described. So he'll give hopefully a bit more detail on this. So again, I would take his word over mine on this, but this is a very general idea about types of brain cancer. Many, many different types. The two most common would be a general category called gliomas. I'll go over that, and meningiomas. And when you take them all as separate entities, meningiomas are the most common. They are considered benign, which we'll get into in general, and they come from a different area of the brain than the gliomas. But those are the two most common types that you will see described. Many other types that you'll see that are much more rare, but when you count them all together will make up the rest of the diagnoses, will be things like an ependymoma, a very weird one called a hemangiopericytoma, PNET, that's supposed to be a T on the end. Sorry, my iPad failed me on that one. And lots of different ones, but the two most common that you will see will be gliomas and meningiomas. Okay, anatomy refresher, or for some people this will be quite fresh. I have 2 slides to go over essentially, or 3 slides, sorry, about neuroanatomy. Again, lots of courses are done on this, so don't hold me to too much of this overall. This is very general overview. There are 2 primary types of brain cells. You have neurons, which essentially are what are responsible for the electrical activity in your brain. They're how I'm able to speak to you at the moment, how you're able to receive the information. They're the primary workhorse essentially of the brain to make sure you get the information you need and transmit it back out. But they also need supporting cells, and these are called the neuroglia or glial cells, are the 2 most common types you'll see in the brain. So glial cells provide nourishment, protection, and structural support, and there are a few different types that have different functions. They were initially named neuroglia because several hundred years ago when they were looking at this, they thought they were the glue that held the brain together. and in concept they were actually pretty close. Other cells include cells of the meninges, which is the tissue layer between the brain and the spinal cord. And there are 3 layers there, but essentially provide some cushioning between your skull and the other bony parts of your body as well, and then the actual sensitive structures of the brain and spinal cord itself. A large percentage of primary brain cancers are of glial origin, and that's frankly where most of my focus will be, because that's my relative expertise area, what I'm more familiar with, and relatively most common. Names for this include an astrocytoma or oligodendroglioma. Astrocytes, specifically as cells, are basically structural support around the cell. Oligodendroglial cells are responsible for maintaining what's something called the myelin sheath, which is surrounding most neurons, and they're responsible for basically making sure electrical impulses get transmitted faster. Essentially that means that if we didn't have that, I wouldn't be able to speak to you very well right now. It would be very, very slow. We're not able to move as quickly with that, or act as quickly. But those are just 2 examples of common things you might hear stated as a diagnosis. All right, I have no idea what happened here. Essentially, what that top part is going to try to say is there are 2 hemispheres in the brain and 4 lobes. So the brain's divided into half, left and right. And then 4 lobes, there are, what the heck happened? I fixed this yesterday and it decided to fix itself again. So my apologies for that. If we need to post this, I will try and get the more updated one to you so that it's not as confusing. Frontal lobe, generally responsible for things like personality, a bit of memory, cognition, as well as things like what they call memory or executive function, so decision making. As well as expressive language, so being able to actually express what you are thinking. The parietal lobe is responsible for predominantly perception and sensation. Temporal lobe, and I'll show you where these are in the next slide, but essentially on either side of where your ears are, essentially, so hearing sensation, as well as memory and receptive language, so being able to understand what you're reading or what you're being told. And then the occipital lobe, more in the back of the head, is responsible predominantly for vision. So a neurologist might kill me for this because there are so many other things that the lobes do, but that's a very general thing. And then people will talk about left brain versus right brain. I'm not going to get into that too much, other than to say for most people, the left side is dominant. So if you have an issue on the right side, say in the language area, what would be language area versus the left, you might have more issues because most people, for whatever reason, the left side of the brain is their dominant side. The left side, if I remember correct, well, I'm not going to do that because I can't remember left versus right. You'll see, I think right-sided will end up being more emotional, and left side will end up being a bit more on the rational side. There are lots of debates about whether that's even true anymore, depending on what your dominant side is, etc. That's a very general idea of what function of the brain, and that becomes important a little bit later on that we'll go over. So this is a nice colored diagram of the brain. So you have the frontal lobe here, again, personality, memory, expressing language. Parietal lobe, so a bit more towards the back top part of your head. Temporal lobe, so this will overlie essentially your ear, and then the occipital lobe in the back. 2 primary areas that are probably of most concern for any neurologist, neurosurgeon, or even a patient is an area called the central fissure. So this divides the frontal lobe from the parietal lobe on either side, and you have something before and after it called the precentral and postcentral gyri. So these are areas of the brain near the top on the cortex. The precentral is also called the motor cortex. So this is what controls all movements in your body, and you can actually map what it controls from your ability to speak to your arm movement, leg movement, etc. Post-central will be your sensation, so your ability to localize something. So if you burn something, this is the area that will help you localize where that pain may be. Again, very generally stated. You can actually, neurosurgeons have done this, you can stimulate certain areas and figure out exactly what area of the brain you're at. And we'll get into a little bit why that's important later on, but location is very important depending on what kind of cancer, where your tumor is, because If you have it in one of those areas, it's a lot more difficult necessarily. It can be difficult to get at because you can cause a lot of injury to it, or that may be where symptoms come from if they're in that area. So classifying brain cancer, and this is actually where Dr. Van Landeghem will have a little more input. The standard that has been done is World Health Organization. They did try and do a TNM, the tumor node metastasis, but that doesn't work very well because tumor size doesn't matter as much as what type of cell it comes from. There are no lymph nodes in the central nervous system, so that's pretty useless for staging someone or grading it. And metastasis, it's quite rare for brain cancer to go outside of the central nervous system. We'll get into it a little bit more. But in general, the World Health Organization system is based off the cell of origin, so what did it look like compared to a normal cell, the grading, as well as other pathological features. They've gotten a lot more fancy these days with a lot of different tests they can do to more specifically look at or figure out what type of cancer this will be. That includes other genetic markers, something they call immunohistochemistry, so different antibodies that they can use to test it. But at its most basic, you look at it under a microscope and you try and figure out where it came from and how aggressive it is. Grades from 1 to 4, kind of similar to what I showed before, is a very general grading system. Low grade terminology is usually applied to grades 1 and 2, and higher grade is usually 3 or 4. We don't use those as great diagnoses because they can indicate, they don't give the best indication of how severe it may be. However, it is sometimes a term you'll hear used. Not all tumor types, or not all cancer types, have 4 grades, and I'll give a bit of an example of that in a minute. And generally speaking, though, lower grade means it's slower growing. So a couple of examples. When you look at astrocytoma, which is the most common glial cell, you have it ranging from grade 1 to 4. The first one, grade 1, is most common in children. It's called epileptic astrocytoma, or that's one of the terms used for it. And then it ranges all the way up to grade 2, 3, and then grade 4. Grade 4 for astrocytoma is the most common type of glioma. It is also the most aggressive. And then meningioma, on the flip side, the most common type of meningioma is the grade 1, which is considered benign. And we'll talk about that in a minute, but then you can range up to grade 2 and 3. Notice there's no grade 4. I don't understand how they come up with these. That's just, there are many more smart people than me came up with this, these classifications. These will be adjusting in the future as well as more studies are done and looking at more specific information too, and Dr. Van Landeghem may go over that as well, I think. So stay tuned for that. Benign versus malignant. So this is a bit of an area of controversy, and I'll preface this with, this is my opinion. This is by no means the opinion of the medical establishment. Benign will generally refer to something that's lower grade. Malignant will refer to something that's higher grade, but it's not the most accurate description, I don't find. Benign, for some people, I actually think it's not a great term to use because it can give a bit of a false sense of security. Just because something is benign doesn't mean it can't kill you. If you have a benign cancer in your brainstem, that is just as much of a problem as if it was malignant. It may not be able to spread very far, but it's in a bad location. On the flip side of that, if you do have something lower grade or something called benign, so no ability to invade other tissue in the brain, that is good if you can get at it. But most brain tumors, I'm putting myself out a bit of a limb here, but most of them will be what we would consider relatively malignant, at least most of the ones that I deal with in gliomas. Meaning that even some of the lower grades, when you look at it under a microscope, they will be starting to invade into other brain tissue, which is one of the hallmarks of cancer itself. Now, they just vary how quickly they may grow. So you may have a malignant tumor that's low grade, very slow growing, maybe several years before it causes any problems, or maybe higher grade growing quickly. Overall, when it comes to benign versus malignant, most important thing to remember is what grade is it, essentially, how fast is it growing, and essentially where will it be. Causes and risk factors. Only known causative risk factor, so known to cause brain cancer, is previous therapeutic radiation to the head or surrounding areas. So that means you basically have to have been treated before with radiation treatment. This is a bit more common because back in, say, the 60s and 70s, they did things like radiation treatment for benign, say, skin tumors. And then they found later on that some people, or a higher percentage than they would expect, actually end up getting brain tumors because the radiation can cause damage. But that's the only known cause of brain cancer that has been found in studies. Other things that have been looked at, genetics, there are some genetic syndromes that are inherited that can cause brain cancer. However, it's a pretty small number, about, you know, the guess in studies is about 1%. That's probably a bit low. It's probably maybe somewhere around 5 to 10%. These are the things, the main one that I'm familiar with is neurofibromatosis, as well as things like von Hippel-Lindau syndrome, but in general they're quite rare. They do account for some of it, but not for all of it by any means. Environmental exposures, relatively unknown. This includes chemical exposures. So there are many things implicated, but most cases you can find studies that say, yes, this is a risk, and you can find others that say we found no risk at all. Not that helpful, but things that have been implicated are things like pesticides, as well as other, you know, compounds you'll commonly find actually in some of our oil and gas industry. There's questions about exposure for that. Yep.
Vaccinations? Is that, can they, no?
No link that I'm aware of. Yep. That's something that is not related. And this is probably the biggest one that people have questions about, is cell phone use. Studies to date, no evidence of any risk involved. The studies, however, aren't of the greatest quality. When you look at their methodology, so the way they did the study, you have a lot of questions about how they actually did it and how they got to their conclusion. And most of the studies that I'm familiar with, the ones that were reported, are back from the early 2000s. We use a lot more of us use cell phones these days than even we did 5 years ago. So it's going to be very difficult to pin that down. Now, the World Health Organization has labeled that as a potential carcinogen. All that means is that basically there's a hint that there may be some problem, but there's no definitive evidence. And with cell phones overall, again, it's just going to be very, very difficult to pin down what's the actual cause of it, because we have other things that could be causing it too. It's hard to control for that. It's also not ionizing radiation. So ionizing means that it causes changes in the surrounding area of chemically. Electromagnetic fields, which are what cell phones are based off of, don't do that. They may have other effects we're not aware of, but they don't have the same risk as the ionizing radiation. Overall, a lot more research is needed. This is where the rarity of the brain cancer hinders us somewhat, because it's not common and it can be very confusing to parcel out what the causes are. But there are some hints there that are there to be followed. Alright, biology of brain cancer. So the adult brain, traditionally is considered to not heal very well when you consider people who have a stroke and try to recover from that. And that's the neurons in particular. Neurons aren't really considered able to divide. That's neuro research coming out. There is some ability for regeneration and retraining, essentially, of the brain to get back to normal function or to have a different function. However, generally speaking, that will still apply. It takes a lot longer than other tissues in the body. However, the glial cells, so the supportive cells and other cells in the body that aren't neurons, do have the ability to multiply and divide, so they can help support the system, and that's where most of the cancers come from. It's extremely rare to see an actual cancer of a nerve, so a neuron. Most of the cancers come from the other cells in the central nervous system. In terms of transforming into cancer, it's essentially the same process, just by different mechanisms, different genetic injuries, but the concept is the same. There's some kind of damage in the DNA that isn't picked up, or the cell doesn't die for whatever reason, picks up more mutations as it goes along, starts growing. So that process in general is the same. It might get there by a slightly different avenue, but the process is the same. Invasion into surrounding tissue is common with most brain cancers. They'll generally spread along nerve fibers. When you look at it, it's a little weird to see, because you'll see if you're looking under a microscope, you may actually see normal tissue, and then you'll see this infiltration in between. So sometimes it doesn't even shove things to the side, which can be common, but it'll actually go in between the different tissues and spread along that to different areas. And it can also start new blood vessels, a process called angiogenesis, which is a common feature, especially in the more aggressive types. In the more benign or lower grade types, not so much. Spread outside of the CNS, so outside of the brain or spinal cord, is extraordinarily rare. There are a variety of theories as to why that is. The really aggressive types don't have as great a prognosis, and maybe we just, if we get more successful treatments, people live longer, we'll see this. But there are only a few case reports of something going outside of the brain or central nervous system. One of the theories is that there are no lymph nodes, so there's no lymphatic drainage, which is a common type of way of spread in other cancers. But this will also depend on something called histology, or essentially what type of cancer it is. The ones that have more of what they call sarcoma or connective tissue component, even though they're in the brain, they for some reason are able to more easily spread outside. But generally speaking, it's extremely rare for brain tumors or in the central nervous system to spread outside of that area. They will spread within the central nervous system, but that's more of a local thing. I personally think it causes enough of a problem where it is, and that's why it doesn't want to go outside. All right. Any questions? I know it's a Saturday morning, so okay. Great. So treating brain cancer, again, this is where treading a little carefully here, but this is a very general, I have to keep saying this is very general. So your own specific case or family member's specific case may be very different. There are three primary options for brain cancer and for cancer in general: surgery, radiation therapy, and chemotherapy. The use of each of these depends on many factors, and that includes your cancer type, the grade of the tumor, success of other treatments, or if there are any that have come before, as well as in particular the location. It's probably the most critical piece versus any other cancer is where is it. So surgery in most cancer areas, including brain cancer, it's long considered the most important component of your cancer treatment for a couple of reasons. It addresses local cancer control though, so if it has happened to go elsewhere, it won't address that. But it does allow for tissue diagnosis, which can help guide further treatment options. If you know what you're dealing with, you may only need surgery, you may have a recommendation to get other treatments or not. But not everyone gets it right away. It depends on, when you're doing the staging part, where is it, what does it look like, as best as you can tell. If you think it's, say, maybe lower grade or benign and you're not having very many symptoms, surgery, neurosurgery in particular, is not something to be undertaken lightly. It's very complex, and you may end up with more side effects than you would have by waiting to do it later on. So in some cases, you will have a delay in surgery, where they'll do something called observation. It is a legitimate option for many, many people, depending on what your symptoms are and what they look like. But in some cases, you will have it immediately done, especially if you're having lots of symptoms. If you do surgery, they will often do what's called a maximum safe resection. So essentially, they'll get as much as they can without causing damage. This may range from something like a small biopsy just to get a tissue diagnosis to see what we're really dealing with as best as we can tell, to removing the entire tumor. Now, this is going back a bit to benign. If your location's okay, usually if you're able to remove the whole thing and it's benign, it's a little easier to remove because it hasn't infiltrated other brain. Otherwise, it's very difficult to get the whole thing if it has already started to do that. That's where some of those definitions come into, in terms of what they think it may be. Mentioned this before a couple of times. It's like real estate. The location. Location is absolutely crucial to whether you can even do surgery at all or how successful it may be. Clinically silent areas, which can include a bunch of your frontal lobe areas, while they do change personality in many cases, something can actually hide there for a long time, or you may not be bothered by it, or they can take out a whole big chunk of it and you won't be necessarily bothered by it, versus if you're in a crucial area of function, like your speech or motor areas, those are much more difficult to actually get at. With that said, surgical techniques do continue to improve. Our neurosurgeons are, especially here in Alberta, are phenomenally talented. They're extremely well trained, and they frankly amaze me with their ability to go in and do very, very sensitive surgeries when it looks like there's no possibility of doing that, and have pretty good success. So something that has come up lately, you may have heard at the U of A hospital here, they do have now an intraoperative MRI scanner. So what that will enable you to do, so what they'll do, they'll go in, they'll start the surgery, and then at some point they'll stop, they'll pause, they have to all get out of the room, they have to unscrub and everything, and then they'll do a scan to see what it looks like, and sometimes you're able to tell, oh, there's probably some more cancer there, where are some of the other sensitive areas, and sometimes they'll go back in and actually take more out, hopefully for more successful surgery. They don't use this for everyone for a couple of reasons. It takes a lot more time to do it, so they use it right now for more specific cases where they think it will be, the neurosurgeons will determine if they think it's going to be useful or not, because there are some cases where it won't, you know, they may know where it is or won't matter as much. But things like that keep evolving with the technology that enable them to be more successful, as well as they do things like mapping of your brain in terms of where your function is, so they can figure out what kind of damage they may cause, if any. Okay, where am I here? Radiation therapy is the use of energy particles to locally treat cancer. And so surgery and radiation are local. So where the tumor is located, you're going after it in that spot. Usually they'll have a little bit of a margin to treat some of the areas around. But essentially this is a really fancy x-ray. So if you go get an x-ray of your chest done, or even a CT scan, they're taking some of that same energy that's created to give you a picture, basically ramping it up and making it very, very specific to a certain area, causing damage to your DNA of cancer cells, and so it will impair the cell repair and division that they have. Generally speaking, healthy cells are also affected, but they're usually better able to recover. Usually. Complex planning is involved, especially when it comes to brain cancer, so you usually get casts and molds. You go for a CT simulation where they try and find the right angles, as well as an MRI planning, or MRI to help plan it. And it's obviously important to ensure accurate targeting. You want to try and make sure you're hitting the exact same spot every time, so that's where usually most people get fitted with a mask to make sure you're in the right angle, the correct angle for that. And they try and avoid as much normal tissue as possible. This isn't a brain example, but here's a bit of an idea. So I don't think this is one we have downstairs, but it basically, these will rotate around. But this is essentially what one version of a radiation machine will look like. It's called a linear accelerator usually. So again, really fancy X-ray machine. Radiation oncologist probably is cringing somewhere. And then here, this is a targeting, I think, a lung tumor, but they have a bunch of different angles that they're trying to put everything together for, and you're aiming for the tumor but not trying to hit the heart. So that's basically the only reason I put this up here. A lot of fancy software that helps us more accurately target where we're at. Sorry, I didn't have a brain one to show. Okay, it is commonly used in a variety of brain cancers, most commonly in gliomas, especially higher grade. But again, the type of cancer will determine whether it's effective or not, or whether trials have been done in it, etc. There are side effects, as with any treatment, and they can include things like fatigue, nausea and vomiting, headaches from increased pressure and swelling, as well as changes to motor function, sensation, as well as memory changes. Not everyone gets all of these, not even close. And some people get none, some people get a lot, some people get in the middle. But there are some side, and they usually will build. They don't usually start right away, because what they will do also is they do something called fractionation. They don't give you the whole dose of what they intend at once, because that it doesn't matter where you aim it, that would really harm you. They split up the dose over a time frame. The most common is somewhere between 3 and 6 weeks, where you come for just one little bout of it and they just divide that up. Chemotherapy, technically, is just the use of medications to treat cancer, and this is systemically. So this is throughout essentially the whole body. So you're not just trying to treat the exact area where the cancer may be, you're trying to also treat where it may have gotten to that you may not be able to see on a scan. Like a few cells that are scattered here or there, you won't be able to pick up yet to date on the scans that we have available. These medications are often toxic, so they're often much more harmful medications if you took it normally, but there is a purpose to it. We're not trying to poison you by any means. It will interfere with cell division and repair. It will also interfere with normal cell division and repair, but usually the normal cells will recover, and the idea being that the cancer cells can't because they don't have that ability anymore, or not as much of an ability. Most of these medications, though, with some more recent exceptions, are non-specific, so they will target cancer and non-cancer cells. Basically, anything that's dividing is what you're aiming to get at, because in theory cancer cells they've lost control of growth, so a lot of them are in states of division, but so are lots of your normal cells. You don't hear about it as much in brain cancer. It can be useful, but it's more limited, and it's because of a literal barrier in most cases, the blood-brain barrier. So the brain likes to insulate itself from anything that's toxic, and so it has a very specific mechanism by which it will allow certain things into the brain. Most medications that they've tried do not cross that barrier, and so you don't actually get it into the brain. That's why our options are usually more limited. There are some, and we do have some that are fairly successful for some people, but this is not. This is partly the reason. You might hear other people using chemotherapy for other cancer types, much more commonly. They don't have to deal with this blood-brain barrier. They've been able to use a variety of different medications. It is usually most effective, though, in higher grade cancers, because those are usually growing faster, so there's more dividing overall. Side effects essentially relate to what it's doing in terms of killing cells that are growing, including your normal ones. So you can get things like fatigue. It's probably the most common symptom that people will complain of. They feel tired all the time to varying degrees. Nausea and vomiting is pretty common because the gut cells are always replicating in your body, so that can happen. Low blood counts, and you're always producing new blood cells, so if you impact that, you can get low blood counts overall, so risks for infection. And you can get appetite and taste changes. There are about 50 million other side effects, but those are some of the most common ones, especially in the drugs that we use in the brain cancer world. So with me stating, it's useful but limited, why the heck do we use it at all? Well, it is effective in some of our cancers that we deal with, especially the ones that, as mentioned, my tumor group tends to be the higher grade gliomas, and that's where we use it the most. There's ongoing improvement in cancer knowledge as well as drug development, so they're trying to come up with more specific targets, so that's an area of active research, as well as the fact that you can only do surgery and radiation so many times. So usually, radiation in particular is a one-shot deal. There's a maximum tolerance to every area of the body for radiation, and they, in many cases, try to go there for radiation treatment if they use it. You can't usually go back without causing a lot more side effects. Surgery, again, depends on location. If they can't do it, or if they've done it a couple of times and they can't do it anymore, there are lots of potential consequences for that they may not want to do that, and therefore chemotherapy, we start looking at that to see if it will help control things. All right, so we're getting towards the end here. I think I'm getting a little over, I'm not sure where I'm at, a little over time I think, but no? Okay. Not too much left. So a couple of major clinical symptoms I want to go over, as well as a couple of very general concepts. So generally speaking, in terms of giving an overview of symptoms, this will depend on what type of cancer you have, which you'll hear me say a lot of. It doesn't make it any less true, but it depends on your rate of growth as well as your cancer location. So if it's growing very, very quickly, you'll usually notice symptoms very, very quickly, and they might be quite severe. If it's very slow growing, it may be something that only happens very slowly over time and isn't really noticeable until you look back on it. And then location, of course, is very, very important. So symptoms are often progressive. So it'll start as something, maybe you have a very small headache, and then over time it progresses to a really bad one that's there all the time versus there off and on. And then you can basically divide them into general symptoms versus very focal or specific symptoms. General ones are usually due to increased pressure in the brain or central nervous system or in the spinal cord, usually in the brain. One of the most common being headaches. You can get things like dizziness, nausea and vomiting, personality changes, double vision that can be related to the increased pressure in your head. Focal symptoms are often considered seizures. It doesn't have to be a specific area of the brain, but if there's a seizure focus in the brain, that will cause, that is more focal, because it's a very specific area usually. They can be generalized, but they're usually focal. Otherwise, it will depend on location. So if there's, if the cancer or tumor happens to be in your speech area, you might have trouble with either speaking or making sense of someone speaking to you. If it's in the motor area, you might have trouble with that. If it's a large tumor on one side, you may have symptoms like a stroke where you have lots of weakness on one side. Lack of balance. Some people have hormone imbalances because a lot of the hormones in our body are initiated in the center areas of our brain, pituitary gland, hypothalamus. So it really does depend on where it is. All right, moving on to seizures. So this is a disruption in the normal electrical activity in the brain. There are a few different types, I won't go into too much, but basically you can have things like simple partial, complex partial, and generalized, or something that people usually call a grand mal. They don't usually call it that anymore in the textbooks. It's tonic-clonic. So that generalized is the one that's most obvious because someone will basically go completely rigid and then start shaking and they will lose consciousness. Warning signs, some people experience them, some people don't. There are sometimes aura that people will experience, so they know they're going to have a seizure. They'll have a sensation like some kind of smell will occur, or they get some kind of visual change, but not the most common. It's one of the more common types of symptoms though, especially in lower grade cancers. I'm not entirely sure why, but especially low grade gliomas, they will experience that more. In terms of what to do if a seizure occurs, so I want to highlight this in case you come across someone who does have a seizure or a family member that does. One of the things you do want to do if you can remember, is document, or at least write it down later. So when did it start? So how long? And what happened? So did someone just have basically a twitch of the arm? That would be considered more of a simple partial. Did they have an aura? Did they have a full-on generalized seizure? If they do have a seizure, you want to make sure the area is clear of any hazards. So if there's, just make sure you get any chairs or tables out of the way as best you can, but do not restrain anyone. Don't put anything in their mouth, and no one should actually drink or eat anything unless you're sure they're fully awake and alert and can actually take something. You do want to place them on the side as soon as possible if that does occur. It's called a recovery position if you've taken first aid. You want to stay with the person and provide reassurance. And then I would recommend that if it's the first instance, regardless of what it is, if you think it's a seizure or something more major, call an ambulance or get to a hospital. Other reasons to call an ambulance or get to hospital, call for medical assistance, is if it's a generalized seizure, unless it's a really common occurrence where you're able to manage it and you have experience with that. If it's generalized, you're going to need some help and get assessed at a hospital where they might need to add medications or fiddle with that. If a seizure lasts longer than about 5 to 10 minutes, or if a second one occurs, so the first one stops but a second one occurs in a very short period of time, that needs usually more attention, because you can go into something, the worst case scenarios, they go into something called status epilepticus, where you're constantly having seizures, either constantly or one right after the other, and that can cause a lot of damage. There are medications that can be initiated that can stop that, so that's why you want to call for help. I don't want to be depressing with that, but if that does happen, it's not the most common of occurrences for everyone in this room, but those are some general thoughts on what you could do. And treatments will include things like anti-epileptic or anti-seizure medication. Some people will, managing stress, ensuring adequate sleep if you can, as well as avoid alcohol or recreational drugs. So the bottom point, the alcohol or recreational drugs, mostly relates to the fact that they can lower something called the seizure threshold. So there is an electrical activity always going on in your brain. If you take something that will lower that threshold for a seizure to occur, then you can get that more often. Not the most common, but it can occur. Most common treatments you usually see in terms of medications are anti-epileptics. And the last symptom I want to go over, or the second one I should say, is memory loss. So this isn't in a lot of the textbooks per se, but it's probably the most common complaint or common concern I hear from patients and family members. Usually it's short-term to start. Most people's long-term memory is usually intact, but short-term, some people don't remember very well on a general basis, and this might make something worse. It's always unclear what it's related to. Is it related to the cancer itself in terms of the impact it's had in the area? Is it related to surgery that's been completed, radiation therapy, chemotherapy? I usually don't blame chemotherapy for that one. The other treatments cause enough damage on the cancer itself, but it is commonly described by people. not a lot we have to do about that currently. A lot of it is basically coming up with strategies to try and engage yourself in or family members in to put things in place so that you hopefully don't forget things as well. So having structure can sometimes help. There are some resources out there, but not a heck of a lot. We do engage some of our colleagues at the Glenrose at times because they have some similar concerns with people, say, with stroke and having memory issues, but not a lot out there at the present time that can really be very, very helpful other than trying to put structure in place for yourself. Okay, so a couple of common medications I want to go over, and the most common one, or the one I wanted to mention the most, is something called dexamethasone. So this is a steroid medication, but not the kind of steroid that you necessarily want to get. This does not build muscle. If anything, it actually breaks down muscle. So this isn't your typical roid, as it were. The primary use for dexamethasone is to control increased pressure in the head or in the central nervous system, which can be caused by brain cancers. It is very effective in many cases, but it has a horrendous amount of side effects, especially the longer you are on it. So we try and keep you on it, if you are on it, the least amount possible. Sometimes we're forced into that just because symptoms require control, but it can include things like trouble sleeping or irritability. So for the sleeping part, we usually try and have you take it earlier in the day, if you do require to take it. Increased appetite and weight gain. Some people will just say they went from having no appetite to they're eating everything in sight. It's a common occurrence with this type of medication. And with that, you will of course gain weight. You can also gain fluid weight with a consequence of the medication overall. Can cause muscle weakness over time, especially in the upper arms and upper legs. So going from sitting to standing can be more difficult. Again, more over time. It can frankly cause diabetes or cause your blood sugar to rise. So if you already have diabetes, this is a difficult one to manage or requires more management. And it can cause stomach upset and heartburn. So it's usually given also with something like could even be just simple Tums or something over the counter to control acid in the stomach to try and prevent that from being a problem. If this is stopped, there is a taper usually required unless you just get a very short pulse of it, like less than 2 weeks. If you're on it longer term, the body gets used to having it provided. So your adrenal glands produce the hormone that this gives you more of, cortisol. And as you come down on the steroid, the body has to kick back in and produce more of that itself. So if it doesn't do that, sometimes it's a bit sluggish, you can get withdrawal, which is essentially usually extreme fatigue. Usually going back to a different dose level will encourage that, will help that, and then you can hopefully just more slowly go down. But the main point there is, if you happen to ever be on it or have a family member that starts on it, unless it's very, very quick, a very, very short time period, you should come off it relatively slowly, or there should be some kind of taper prescribed. And then anti-epileptics or anti-seizure medications, commonly seen, of course, if you have a seizure. They're often used in a surgical setting, what they call adjuvantly, or trying to, even if you don't have seizure issues, to try and control for any that might happen post-surgery. But then they're usually quickly stopped if you don't have seizures overall. But some common ones that you will see, there's some really old ones, which are still good, like Dilantin or Tegretol. But they can cause a lot of issues in terms of interactions with other medications, as they can also impact and cause lower blood counts. So that becomes more of a problem if you get chemotherapy. So some of the newer ones don't cause interactions with chemotherapy or other medications, which include something called Keppra or levetiracetam. People always love trying, and I always love trying to say the actual generic name is usually much more difficult than the trade name. So there's usually a trade name that's easier to say. Keppra is one that we use a lot of. Most people tolerate it fairly well. Does not interact with a lot of other things that we're aware of. So it's more chemo-friendly for us. So those are some names you may see. There are probably at least 10 others that some people will be on. And some require multiple mixes of them to make sure your seizures are under control if you have them. Okay, so I'm going to wrap up here. So in general, primary brain cancers are rare. So metastases from other tumors are much more common. Similar techniques to control those may be, so surgery, radiation therapy, and chemotherapy may be used for metastatic disease as well from elsewhere, but we focused obviously today more on the primary ones. The most common types of primary brain cancers are gliomas, and meningiomas. The type and grading of cancer is extremely important to determine what they call prognosis, so how well one would expect to do, as well as treatment options. Treatments will include could include surgery, radiation therapy, and chemotherapy. Common symptoms include headache, memory issues, and seizures. And then common medications can include things like dexamethasone, as well as the any of the anti-epileptics, anti-seizure medications. Okay, thank you very much for your time today, and I hope you enjoy the rest of the morning.